So welcome. We are currently at the second Pediatric GI Connect meeting in Hollywood, Florida. I'm here with Dr. Miguel Saps, one of the leaders in our field of pediatric neurogastroenterology motility, and specifically an expert in this topic today, which is pediatric constipation. He is the endowed chief of the division of GI at the University of Miami. I'm Peter Liu. I'm a pediatric gastroenterologist from Columbus, Ohio. So thanks for joining.
Thank you, Peter.
All right, so I was thinking today we can talk about this very common problem of childhood constipation, maybe start from some of the basics and then kind of move through some of the newer things that are coming out in the field. So first of all, I think a common thing that we see is when families come to us and ask for a more natural, perhaps, way of treating their child's constipation. What do you think about that? Are there natural options that are effective, and what do you think?
So thank you, Peter. That's a great question. So that's something, first, constipation, it's very common in children. It's like 10% of all children. So we don't have to be, it's not unusual if you're a child or if you're an adolescent with constipation. So 10% of everybody, all the children of your age or adolescents will have constipation. And in most cases, we try to give natural treatments. However, there are some of them, it's important to remember that some of them there is not enough evidence. They are okay to be tried, but there is no real evidence. Water. So water, I see many people that they say, my son, my daughter is drinking enough water. I don't know why they have constipation. Okay, unless you're in the desert or in the middle of Miami here, but in the summer, not drinking enough water is not the reason of your constipation. Mm-hmm. And drinking too much water is not going to solve constipation. I was mentioning today that I haven't met anybody who drank a lot of water and got diarrhea. Right, that just doesn't exist. If you drink a lot of water, you just pee a lot. So it doesn't come out with the stools. It doesn't change the content of water in the stool. So drinking water is not the solution. Everybody should drink water like normal. Mm-hmm. And same thing with fiber. Fiber, everybody should have fiber in normal amounts. Excessive amount of fiber may even be detrimental, bad. So fiber, yes, and water, like everybody else, should have normal amount of water and fiber. That's not the solution to the constipation. Probiotics. I see many of the patients that come with probiotics. There is absolutely no evidence that probiotics solve the problem. In fact, if you look at yogurts and all these things that they have probiotics, they don't say that they treat constipation, and because they don't treat constipation.
Right.
So they say something like for the healthy gut or things that are like very, I don't know really what they mean, but that is a different thing. So, but there are, we are in an epidemic of obesity, so I'm not saying that juice is a solution, drink a lot of juice, but that juice helps. Many times in children, younger children, the parents give them juice and it's okay. We don't want to give too much juice because we don't want to get the people to obese. We know obesity, diarrhea, or liver problems, so we need to be careful, but juices work. Kiwis, prunes, some fruits work. But if that didn't work, I think you need to consult and we need to move on maybe to medications.
Right. So I think, there's been a lot of research, of course, on all the different medications we have available for childhood constipation, and polyethylene glycol, 3350. So that's kind of come out as the one that's not only effective, but also best tolerated for children. But I think there's a lot of concern out there about the safety of PEG. So what do you think about that? Like the concerns about maybe breaking down into metabolites that can be neurotoxic or lead to behavioral changes. Is there any truth to that? What do you think?
So there is no evidence for that. The reason that many people associate that is because children who have neuropsychiatric problems or ADHD or autism frequently have constipation. Mm-hmm. So sometimes the time of onset is sort of at the end they're giving polyethylene glycol. So sometimes there are early signs of some neuropsychiatric or neurodevelopmental problem. And as they're giving polyethylene glycol as the most common used drug, they think, that's what happened. But really, that's not the reason. It has not been shown. It has been shown so far to be a very efficacious and very safe drug. There are some ongoing studies, but so far there have been tens of studies. All of them, they're being safe. I usually highlight to all my patients, a study was done in Columbus, actually where you are now, Peter. And in that study, I thought it was a great study, very smart. They drew blood from children who were taking polyethylene glycol and the siblings who were not taking polyethylene glycol. And the amount of metabolites that is a surrogate, it means how much polyethylene glycol you will have in blood. It was exactly the same. It was very interesting because that not only means that polyethylene glycol doesn't get absorbed, but also that everybody has polyethylene glycol. And there are like 200 products, like teas and ice cream, and it's used for in industry, like for foods, because it just make it more palatable. Mm-hmm. So they put a lot of polyethylene glycol. Also, there is polyethylene glycol in some of the containers of the glasses and plastic things. So we all have, unfortunately, contamination of different products. So that doesn't mean that polyethylene glycol, the one we use in medicine, is the one getting absorbed.
Yeah. And I think the other thing is, the amounts that they did detect were far below any potential, threshold for safety. So yeah, I bring that up all the time as well. I'd say most patients will respond to, daily or as needed use of a stool softener or osmotic laxative, but certainly there are some who don't and need a stimulant laxative. I think many families like Senna since it's a plant-based laxative, and there's some thought. I guess the perception is that maybe safer. Mm-hmm. But there's also a lot of concern out there, even amongst pediatricians, about the safety of regular use of a stimulant. Is it going to make the colon lazy or dependent? What do you think about that?
Yeah, I get that all the time. I would say that 50% of the parents I see in clinic, they ask me, "Is my child going to get used to it?
Right.
Do I get used to it?" And no, there is no evidence that you get used to it. It's like what happened is that if somebody needs something and then get better, let's say for constipation, they get better with Senna, and then they stop the Senna, and now they get worse, and then they take it again, and they do well, they say, "Oh, you got used to it."
Right.
No, you just need it. It's like having a headache, isn't it? You take, any acetaminophen or whatever medication for your headache, you don't think, and you get better, you don't think you got used to that medication. Mm-hmm. You just thought that, okay, I need a medication. So I think that the patients who get better on the medication and then they stop it and they worsen means that they just need it.
Right.
And they may need long-term. And it's safe to use long-term. There is no evidence. Before the 60s, there was a different formulation, and then there were some problems in the colon. But that has been 65 years ago. There were something called cathartic colon. There was like a colon that wasn't respond very well afterwards. That didn't happen. There are no cases published for 65 years, but somehow things that they have been said sometimes persist, and they're
right.
in the internet and other places. And I think it's time to, this is mostly a myth. It's time to educate and to know that they are safe. There are studies and poison control here in the U.S. and studies from your place, Nationwide Children's Hospital, the surgical group, that they use high doses of Senna. And they found that besides having liquid stools that may damage transiently, they have diaper area erythema or redness, or there are no other effects. So you just need to make sure if you have a young child and you give too much Senna, then to change the diapers frequently. If you leave them too many hours in contact with the skin, that may burn the skin transiently. It comes back, the skin. But then it can cause discomfort and pain. But if you make sure that you change the diapers and the stools are not completely watery, then it should be fine.
Yeah. I feel like I always like to point out, I think the thing that makes the colon more lazy is going to be ultimately not treating this adequately, right? And stool retention, and that's really the main problem. Senna is going to be the opposite of that. So
I agree. I agree.
Yeah.
Because if you leave the stools like impaction for too long, you may get elongation and dilation of the sigmoid and the lower colon. So that could be a problem, and then maybe more difficult to treat, and then you have to go into more potent drugs or other treatments that not always medications. So I think that treating early and emphatically with good doses, that's a good thing.
Yeah. So Senna has some benefits in that it's available as a liquid and chewable and as a tablet. But, the alternative stimulant laxative is bisacodyl.
Yeah.
That only comes as a tablet. And I feel like I'll oftentimes see even, people in our center crush those tablets. Yeah. What do you think about that?
So you shouldn't crush it because it comes in enteric coated for a reason. The reason is it acts locally by contact with your colon. So if you crush it, it will be in contact with other parts of your gut that they're not the ones that you want where you want it to act. So usually they can swallow. It's a very small pill, a small tablet. Usually it's very tiny, but crushing it's not a good thing. It shouldn't be taken crushed.
Yeah.
And there is no liquid form, and they cannot make a liquid form of that.
Yeah. So, okay, we've talked about, osmotic laxatives, stool softeners, stimulant laxatives. In a smaller fraction of children, they'll continue to have symptoms despite education and toilet training and also use of these medications. So there's a lot of talk in our field about, how do we effectively evaluate and treat children with refractory constipation, but also a lot of debate about how exactly do we define that. So there was a paper that just came out. How are we supposed to define refractory constipation, and what are your thoughts about that?
That's a good point. Refractory constipation are those children who don't get better over time. So they should have been appropriately treated for more than 3 months with osmotic laxative like polyethylene glycol or lactulose or others like Dr. Lu said, in addition to a stimulant laxative like Senna or bisacodyl like we are mentioning now, would give you the idea that those are safe, isn't it? Because they're telling you to treat at least for 3 months. And those who fail and continue with symptoms, and if we go specifically for the medical, the more specific audience, they should have at least, they define that you should have at least 2 bowel movements per week, or at least 1 or more episodes of fecal incontinence per week. And that is what considered a failure. So that's the definition, this manuscript that Dr. Lu is mentioning. It was the NASPGHAN, the North American Society of Pediatric Gastroenterology, the Motility Committee came out with that recent definition.
Yeah. So in that situation, so if they have refractory symptoms, there are some, in the past few years, some newer medications and treatment options that I think offer a lot of promise. And one of those classes of medications are the secretagogues, of which linaclotide is an example. And can you tell us a little bit more about what does that class of medication do, and what kind of evidence do we have so far about its efficacy and safety?
So linaclotide, so there are 2 secretagogues mainly, lubiprostone, for which there is 1 paper showing some evidence, but in the biggest paper, not the largest, but the better design, it didn't show efficacy compared with placebo. We compare with placebo the drugs in order to see if it's superior to placebo to say if the drug works. So that study, lubiprostone was not efficacious, didn't show efficacy. However, linaclotide, there are a lot of studies. Linaclotide is a GCC agonist. So what it does, it mimics the mechanism of the cholera toxin. They learned that if you have cholera, you get a lot of diarrhea, isn't it? We don't get cholera in the US, but people who used to get cholera, or they get in the third world, they get toned like liters or gallons of diarrhea, and that's why they die of dehydration. So they learn the mechanism, and they say, can we use that same mechanism in order to make a drug that will not kill you, but will increase the water in your stools? And that's how it works. And that's what linaclotide does. It has been approved by the FDA for the last 2 or 3 years for children 6 to 17. It has been approved in adults many years ago for the treatment of functional constipation. And so far, it has been shown efficacy and safety. The only issue is that it may cause more diarrhea, but usually, very rarely, diarrhea is important to the point that there were only very few cases that had to consult for this area. Usually, you just modify the dose, or if it's too much, then it may not be the drug for you. But you can modify the dose, and it comes in a capsule, so you can open you can go up because there are 3 strengths. And if you want to go down, you can open the capsule and put half or whatever you want to put, give from the capsule. So I use it, and I think it's a good drug. The issue is that sometimes insurance companies, like many other things, they deny because everything that's expensive, the insurance companies, there is some tendency not to approve it. And then if you have to pay for it, it becomes very expensive. But it's a good drug.
Well, my understanding is there's also some data, even in younger children, that maybe could lead to some more even younger indications, but we'll see.
Yeah, we hope that in the future there are studies looking at safety at least, They show safety. And there are studies now looking into efficacy in younger children older than 2. It's not recommended. It's against recommendation in children younger than 2, but there are studies in 2 to 6 year old going on. And we'll see what they show.
Yeah.
Like anything else, we need to see what the study shows.
I think the other big, class, or specifically one medication, Prucalopride, that we've been starting to use in this population. That medication, there's been some conflicting research data. Tell us more about that and whether you use that or not.
Yeah, I use it sometimes. At the end, you end up using everything as safe, and Prucalopride is safe. The only issue is that there were some cases of suicidal ideation, so there is a black box warning, so you need to discuss with the patient. So I wouldn't use in somebody who has depression or have psychiatric problems or a risk of depression. But otherwise, the issue with Prucalopride is that it has a different mechanism of action than Linaclotide. This one would increase contractions. And what happened is that there is the study that was placebo-controlled, that's the gold standard, as we said, to compare with placebo, was a negative study. In adults, it's approved for constipation, for functional constipation. The mechanisms of action are different in adults and children because similar lubiprostone and Prucalopride, both of them were approved in adults, and they have positive studies, but in children the mechanisms are different, so they were negative studies. But there is some indication that suggests that Prucalopride may work in the upper GI tract, so sometimes I use in patients who have esophageal problems or gastric motility problems like slow gastric emptying and constipation. I still use it because those patients may benefit. And I try. If it works, it works. Otherwise, you go to the next treatment.
Yeah. So, even though both of those classes or medications offer a lot of promise, there are a lot of other new things that may be coming in the next few years.
Yeah.
Anything exciting that you think maybe is being used in adults or not even in adults yet that you think might be making its way to this population?
So in adults, there is a vibratory capsule. It's approved. I'm saying adult because it's approved in adults by the FDA for the treatment of functional constipation. Those are 5 capsules that you charge like your phone, like has a charger. You swallow, and twice a day they start vibrating for a few minutes. And it seems that it works with circadian rhythm of the colon, and it sparks your colon. And there are studies, not too many studies, but there are at least 2 or 3 studies showing that may be efficacious, and that's how FDA approved. You just poop it, so you don't need to rescue it. Don't worry. And if it's not covered, that something is amazing. Although its technology is very cheap, so I sometimes use it. It's a capsule you need to swallow, so you're not going to give to young children, but adolescents I sometimes use.
Really? So it's not expensive?
It's very cheap.
Wow.
It's very cheap.
Shocking.
I'm surprised how can it be so cheap.
Yeah.
It's sometimes cheaper than medication.
Okay.
So some of the medication at least.
Yeah.
Yeah.
So that's very interesting. And I know you've also done some work that we've also been doing too, looking at neurostimulation for constipation. That's probably not as close to prime time yet, but what do you think about that? Yeah,
I know you have been doing some studies, and I have been doing too, on posterior tibial nerve stimulation. That's like a TENS machine, like you apply in the heel, and then it just gives electrical pulses. And supposedly the way it works is that retrograde goes to the spine and works in the sacral nerves and stimulate those nerves, and that has been shown to improve fecal incontinence, but also other symptoms of functional constipation, but particularly fecal incontinence. So it's promising because it's cheap, it's safe, but it's still not prime time, and it's something probably in the future will be used more and more.
Yeah. Well, thank you so much for joining me for this conversation.
Thank you, Peter. That was great. It was fun, and hopefully people learn something.
Yeah.
Thank you.